interested audiences. This is in webinar mode in Zoom. I'm sure we're all used to that. You will all be in listen-only mode. For Zoom technical problems, please put in a chat message to Oliver Lontock, who is who's curating the webinar with us today. Feel free to enter questions into the Q&A box. We'll be taking breaks along the way in logical times during Kristen's presentation. So you can also save your questions for that time. Since we're not expecting an enormous crowd, I think we'll be able to unmute folks. If you'd rather ask your question in person, just raise your hand and we will get to you. So now it's my pleasure to introduce my colleague, Kristen Lloyd, who is a senior research scientist at the Center for State Health Policy, has worked with us for some time now. She provides data management, statistical analysis, project management support for a variety of projects. Notably, she plays a really key and central role in our work evaluating New Jersey's Medicaid 1115 demonstration waiver and other Medicaid projects. She also has worked extensively on our childhood obesity studies, and also notably for today, when you see estimates from surveys from the center, it's almost always Kristen behind the scenes putting those together. She's quite expert in the preparation and use of national survey data to inform policy here in New Jersey. She received her MPH a few years back in epidemiology from our very own Rutgers School of Public Health. And I would like to turn the microphone over to Kristen to proceed. Thanks.
Thank you, Joel. Good morning, everybody, and thanks for joining us today. As Joel introduced, I'm Kristen Lloyd. I'm a senior research scientist at the center. And today I'm going to be presenting a survey of surveys, which will focus on how health coverage and access to care is measured in New Jersey on 3 longstanding, widely used surveys. I just want to remind participants at this point that the webinar is being audio recorded, and I believe the recording has already started. If not, Oliver, can you do that?
It's on.
Great. Okay. So first, I'd like to acknowledge the Robert Wood Johnson Foundation, because their core support for the center is what makes the webinar possible. I also want to thank my supervisors and colleagues here at the center, Joel, Margaret, Oliver, and Joseph. They're all present today. They've all contributed to organizing the webinar and helping me with the content. I also want to thank Alan Monheit from the School of Public Health and Jane Miller from the Blaustein School, who gave input for the content of the webinar. And last but not least, I do want to acknowledge all the great work that's done by some organizations listed here. They produce resources that were very helpful for me in understanding and utilizing the surveys: the New Jersey Department of Health, the Census Bureau, PUMS, and the State Health Access Data Assistance Center. I did rely heavily on their documentation when preparing the webinar, but all errors in the presentation are mine. So this is the agenda for today. I will stop for really short Q&A breaks in between sections just to answer any clarifying questions, and then there'll be time at the end for more in-depth Q&A. So this is a chart here of the expertise level reported by registrants who are attending the webinar today, or hopefully a random sample of which are attending the webinar today. And from that, I can see that the majority of people are either inexperienced or novice with these surveys, which is perfectly in line with how I'm going to conduct this webinar, which is really going to be going wide on a lot of different topics and, sort of deep in some areas, but mostly it's going to be a very wide overview of these surveys. So the 3 surveys I'm going to be covering today are the American Community Survey, the Behavioral Risk Factor Survey, and the Current Population Survey. So I will cover each section in this alphabetical order and then provide a summary of those 3 surveys to kind of compare and contrast some key features. There's lots of things I can't expand upon just because of time, but we can circle back to it later. And the slide deck, as Joel mentioned, will be posted so you can use it as a reference. The purpose here is to just give you some exposure to the concepts, the content of the surveys, so that you have these features in mind when you're either working with one of them or when you're deciding which one you might want to use for your research. So I'm going to start with what all the surveys have in common. They're all publicly available. The data are free. They're mostly quick to access. Of course, being public, the data are de-identified. The surveys are population-based, so they are meant to produce estimates about a respective target population, which is, for all these surveys, very broad, although slightly different across the three of them, which we'll talk about. The samples are cross-sectional, so when you're looking at repeated annual estimates, it's not the same households or same persons over time. There is a small footnote there with the CPS, which does have some limited longitudinal capability just because of how the sampling is done. But generally, you can think of them as being sources, as cross-sectional samples. They are all designed to do annual estimates. Again, footnote there, the CPS and the ACS do have some ability to do subannual estimates, but that's mostly restricted data and not used very often. All the surveys can provide estimates at the state level. Some of them can do smaller geographies, which we'll talk about. They all do measure health coverage, which is why they were selected for this webinar. And finally, timing-wise, estimates from these surveys are generally released for a given measurement year the following late summer or fall. So right now we're in June of 2022. The estimates pertaining to 2021 are not out yet from these surveys. So the latest data that will be available would be data pertaining to year 2020. Now I'm just going to quickly go through the key features of these surveys. The American Community Survey is done by the United States Census Bureau. This is a general household survey. It started in 2005. It replaced what was the census long form, which used to be collected every 10 years. And now with the ACS, that information is collected annually. So tons of addresses are sampled, survey is mailed, respondents can fill it out on paper, they can go online and do it. And then there's telephone and in-person follow-up for people who haven't responded yet. Because of that structure, this survey can provide both household and person level estimates. It has the largest sample of the three surveys that we'll be talking about today, roughly 2.2 million households per year in the United States. The New Jersey sample is obviously a little smaller than that, about 50 or 60,000 households. Next is the New Jersey Behavioral Risk Factor Survey. This is a component of the BRFS, or the Behavioral Risk Factor Surveillance System. This survey began in 1991, and it is conducted in all 50 states, DC, and some territories. This survey is sponsored by the New Jersey Department of Health. It has technical assistance and funding from the Centers for Disease Control. And as the name suggests, it is designed to monitor behavioral risk factors and chronic conditions. There is a core survey, which has fixed questions, and then questions which rotate in and out on a 2 to 4 year basis. There's also optional modules, which states can choose to administer, and states can also add their own questions to the BRFS. It's a telephone survey done on landline and cell phones. It's collected throughout the year, but it only collects information on an adult respondent. So in this survey, it's only person level estimates. Of the three surveys, this is the medium sample, about 160,000 respondents per year nationally. And in New Jersey, it varies by year, but roughly 11,000 or 12,000 people. I want to note that today there are experts on the webinar from the Jersey Department of Health who work extensively with the BRFS. So I invite them during the Q&A to comment on anything, clarify, and correct as needed. And the third survey is the current population survey. This is also done by the US Census Bureau in partnership with the Bureau of Labor Statistics. It's the oldest of the three surveys. It was developed out of the Great Depression, so it's primarily a labor force participation survey. There are supplements to the CPS, and the annual social and economic supplement is the one that I'll be focusing on today. It's referred to as the ASEC, and that one is the one that collects information on health insurance. So like the ACS, the CPS does address-based sampling. The ASEC is conducted between February and April of each year. Like I mentioned before, the sampling on this is a little technical, but because households do leave and return to the sample, you can have the same household that would be in 2 different years of the data. The respondent answers for themselves and everybody in the household, and the CPS is capable of producing household, family, and person level estimates. It does have the smallest sample of the 3 surveys, about 90 to 100,000 households per year in the US, with the New Jersey sample being smaller than that, like 3,000 or so. I want to introduce the concept of group quarters very briefly, just so you understand which populations each survey is designed to represent. So people live in either housing units or group quarters. Large majority live in housing units. Group quarters are residences like those shown here in the examples, and group quarters are split between those considered institutional group quarters and those considered non-institutional group quarters. And all of the surveys that we're talking about today cover housing units, but they do differ in which group quarters populations are covered in each of the surveys. Also, just because group quarters are included, it doesn't mean that every question in the survey is asked of everybody who resides in group quarters. So you just have to pay attention to those universes when you're working with the data. So this is a summary slide that compares the key features, several of which we've already discussed. I do want to just bring up this concept of the measurement year and the survey year. Most times when you're looking for data on a particular year, you would go to that year's survey. So for instance, the ACS that's conducted in 2019 is going to ask people questions about their status in 2019. But the CPS is different. It has questions that ask about the prior year. So historically, it was like the 2018 CPS-ASEC, which would give you estimates of coverage in year 2017. All of the files, all of the surveys do release single-year files. The ACS also releases a 5-year file. People are often interested in what geographies are available for each survey. So the ACS, because it has a very large sample and because it does have that 5-year file, is capable of producing estimates for various geographies and very small geographies, such as ZCTAs, which are zip code tabulation areas, which are proxies for zip codes, and census blocks, which are the smallest census geography. The BRFS is designed for state level estimates, but it can also do county level estimates when the sample is sufficient. The CPS is designed for national estimates, but there is enough sample oftentimes to do state estimates or estimates for very large metropolitan statistical areas. And finally, as we're heading into the next section on coverage and access, coverage is, questions on coverage exist in all of these surveys, but questions on access are really only on the New Jersey BRFS. So I just want to pause here and just take a look and make sure there's no burning questions or anything that requires clarification up to this point.
So there is a question in the chat from Shinyi about the most current available. I think you partially answered the data lag question, but go ahead. For currently available will be 2020 for each of these surveys. The 2021 should be released late summer, early fall. And remember that because it's available for year 2020, it's actually the 2021 CPS. But the questions there on health insurance and a lot of the other questions on that survey will be asking about the prior year. So it pertains to the 2020 measurement year. Okay. All right, so moving on to coverage and access. This is a picture of the question on insurance coverage from the American Community Survey. This question was introduced in 2008, and respondents go through this questionnaire and check off yes or no for a variety of coverage types, as you can see here. If they don't see the coverage that they have on that list, they can write it in at the bottom. They respond for themselves and for every other person in their household. Multiple sources can be reported per person. And in the ACS, those who are classified as uninsured, when you look at how the census prepares the data, will be those who answered no to all of these questions, or if they only report having Indian Health Service coverage. On the New Jersey BRFS, this is the question that's on the core survey.
It changed after 2020. It used to be a question that just asked if a person had any type of health coverage. And then in 2021, it changed to a question that asks for the primary source of insurance coverage. So for the New Jersey BRFS, you don't have multiple selections per person, it's just one answer. And those who would be classified as uninsured will be those who say they have no coverage of any type. I do want to mention that there is a healthcare access module on the New Jersey BRFS, which New Jersey began using in 2013. It was one of those optional modules. And when this module was used, there was a question on there that did ask about type of insurance, primary insurance, the one used most often. So when you're using the BRFS, if it happens to be a year that has this module, you will have that information on type of insurance and not just insured, uninsured for the years that this module is used. And they also have questions on that module about periods of uninsurance and duration of uninsurance for those who are uninsured. And finally, the CPS. This survey has a really complex method of asking about coverage. I couldn't even show you all the questions on a slide, it's just way too long. But the core question, as I mentioned earlier, is an annual retrospective question. So the person is asked, in the prior year, was anyone in your household covered by, and they go through each of these coverage types and find out, who was covered by any of them in the household. Multiple sources can be reported for each person. The policyholder is identified when you work with the CPS data. If they were talking about employer-sponsored insurance, which is ESI, or direct purchase coverage. If after cycling through all these questions, there's somebody in the household who's left without coverage, then there's a verification question to confirm the person's uninsured. Now, this slide will be in the pack. I'm not going to go through it in great detail, but I do want to let people know that these questions were significantly redesigned. So the CPS currently will have information on current coverage, as well as that retrospective question about coverage in the final year. There's a lot of literature on this, reasons for why it's done, testing. I think it was only for 2019 CPS that you can start getting that data on current coverage. Up until that point, people mostly work with that annual retrospective question, but I do want to just mention that so you're aware of how data are collected currently. So I'm going to recap here just kind of that core information on coverage that's present on all the surveys shown here for the years that are shown in that first row. Both the ACS and the BRFS are giving you that current point in time estimate of coverage, whereas the CPS is asking about point in time coverage in the prior year. And so that means there's a fundamental difference in who is uninsured when you are looking at the CPS ASEC versus the ACS or the BRFS, because on the CPS, they have to be uninsured for all of the prior year and not just at that point in time to be counted as uninsured. The ACS and the ACS and the CPS will give you multiple types of coverage per person, but the BRFS is just whether the person has any coverage, or if it happens to be after 2021 or a year when that module was used, their primary type of coverage. And that's also in the footnote. And the policyholder is collected on the CPS only. So this graph just shows a few recent years of estimates of the uninsured rate for non-elderly adults using the 3 surveys. So what's clear here is that estimates differ depending on the survey that you're looking at, and that the estimates of uninsured from the CPS are lower since they are full year uninsured estimates as opposed to point in time. There is some research that, and this went into the redesign, that the CPS, people were answering it a little bit like a point in time, so it's more of a hybrid measure. There's a lot of literature on that if you're interested, but in general, it is measuring coverage in the last year, and therefore it is a little lower than what you'll get on the other surveys. So this slide shows methodological features that can affect how survey respondents answer these coverage questions and why we're seeing those differences in estimates, besides the point about one being a retrospective question and one being point in time. There's, again, a lot of literature on this. If you're interested in survey methodology and measurement issues, I can't discuss it all. We can come back in the Q&A if you're interested, but I want to mention 2 things. One is whether the survey uses the state names for Medicaid or CHIP. So when the CPS is administered in New Jersey, The words New Jersey Family Care are used to refer to Medicaid CHIP. And in the ACS and the BRFS, it's just referred to as Medicaid. So individuals could be less likely to identify Medicaid as their coverage if that specific name isn't used. The other issue is this concept of the Medicaid undercount. It's known to affect both the ACS and the CPS. It does affect most surveys. I've not seen any explicit mention of it as an issue for the BRFS. There are logical edits that are applied when the data are processed by the stewards, which try to account and correct for some of this, but it doesn't fully take care of it. And just to go a little bit more into the Medicaid undercount, because I know we have some colleagues here from the state Medicaid agency on the line. It is an issue in all surveys, like I said. It is a bigger issue, it seems, in the CPS-ASEC. So SHADAC, that group which I mentioned in the acknowledgements, does some estimates of this undercount by comparing the survey data, and they actually link it with enrollment numbers from administrative data. And on the CPS-ASEC, the undercount is pretty large for New Jersey. They estimate around 30, 35%. The issue seems to be less in the ACS. There's logical edits that do take care of it. And there was some research pretty recently showing that this undercount in the ACS may have been increasing after the Medicaid expansion. The general reason for the undercount is just primarily survey response errors. So now I'm going to jump to what else the surveys capture about coverage in addition to the core questions that I talked about. Post-ACA, there was interest in measuring participation or purchasing of insurance through the exchange. So the ACS did add 2 questions in 2019 to try to get at exchange coverage. And if someone reported private coverage with a premium and a subsidy, that is supposed to proxy coverage purchase via the exchange. And this right side of the slide shows you questions that were added to the CPS during the redesign, which get at marketplace participation and employer-sponsored insurance offers and take-up. There's a link at the bottom if you are interested in more detail on these questions in the CPS. And finally, moving on to healthcare access. So only the BRFS has questions that really fall within that domain of access. The questions from the core survey are shown here. They cover those classic concepts of having a usual place of care, having unmet care due to cost, and whether the respondent had a routine checkup and how long ago it was. There's also the healthcare access module, which, like the name implies, collects questions on access. So there are several other questions on that module. And when it was administered in New Jersey, you'll have these questions available in the data. The topic areas and the questions are listed here. I'm not going to read through them word by word, but you can see that they extend the areas that are covered on the core survey, plus they add some other new topics. So I'm going to pause here too to just double check on any questions.
So we do have one question here, Kristen, in the chat from Sarah, and she says, on the Medicaid undercount in ACS, why is the survey response error seemingly higher for Medicaid beneficiaries?
Yes, so I think a lot of it may have to do with this is some speculation, though there is some good research on this, but not recognizing the name. As if they're used to it being New Jersey Family Care, and in the ACS it is not referred to as that. They may not identify that as their insurance. And it seems that people with Medicaid tend to report that more as private purchase or direct purchase coverage, and it gets grouped into that. So on the ACS, there's not an interviewer guiding the respondent through the survey to help clarify any questions. They're really filling it out on their own. So there's that opportunity for misinterpretation. And I can certainly send you some information on lots of literature that's been done on the Medicaid undercount and why it's there. And I think it's just really chalked up to just error on the respondent's part. Thanks, Joe, for alerting me. Okay. So the next section is going to kind of breeze through some other health-related content that's on these surveys. And this is because often when people are examining coverage and access, they're interested in looking at that in conjunction with health status. So health-related content on the ACS and the CPS is pretty limited because these are not developed as health surveys. The ACS does assess disability status for all members of the household, ages 5 and older. It's these 6 types of disability, and this is the phrasing of the question for collecting that data. The CPS has a single health status question on self-rated health. It's the classic general health status question with the answer choices of excellent, very good, good, fair, or poor. And it has a couple questions on out-of-pocket medical spending and premiums, which is not exactly health status, but is related to health spending. So in contrast, we have the New Jersey BRFS, which has an extensive coverage of questions on health. And that's cornucopia here. That's why I chose this picture. This is just examples of some of the health topics that have been examined either on the core or some of the modules that New Jersey has used. If you're interested in knowing what topics are covered in what years, there's a link at the bottom for each year where you can download each year's survey and you can see exactly what was covered for that particular year. In terms of health-related content, the New Jersey BRFS goes further even in the last year. So their 2022 questionnaire has a module on social determinants of health and health equity, and it assesses the topics that are shown here. Again, just a further advertisement for this very broad and rich health-related content on the New Jersey BRFS. So this slide orders the surveys in terms of certain characteristics that we've discussed with respect to the available detail that's in the data. It is a little subjective, of course, but it's except with sample size, that's not subjective. But this is my interpretation. The ACS has the simplest coverage question and the most consistency in that coverage question over time. The ACS can provide data at a small geography. The CPS, in contrast, has really detailed information on coverage, policyholders, and even if a person in the household is covered by a policyholder outside of the household. But there are more trending issues with the CPS due to that redesign that I mentioned. The ACS and the CPS don't really have a lot on access. They're kind of tied there in the sense of not having much at all. And the BRFS obviously has the most information on access. The CPS has a very small sample size as well, and the BRFS has a medium sample size. But this is just if you're trying to make a decision about which one to use and looking at these topics, how they rank. Okay. And next, I want to touch on just other demographic data that's collected on the surveys, specifically race, ethnicity, and data on gender identity and sexual orientation, because those are topics that are really relevant for health equity research. What I'm going to present to you is what's collected as of the current version of the survey, and just be aware that this isn't necessarily what is available in the data that you can access because of confidentiality issues. Small categories are not going to be reported. At the minimum, these surveys have to or do collect race and ethnicity information that will allow for grouping into the 5 race groups that are designated by the Office of Management and Budget, and that's white, Black or African American, American Indian or Alaskan Native, Asian, Native Hawaiian or other Pacific Islander, with a category for other. So back to the ACS. This is the questions for collecting race and ethnicity data. On the ACS, respondents can select more than one category, and there are write-in fields, as you can see here, though those detailed responses will not often be found in the public data because they need to meet minimum reporting requirements. Also, when you go to access data from the ACS on tables that are generated by the census, they use the approach of grouping individuals as into race groups alone. So those who report only being white, only being Black or African American, only being Asian, and then one group that is 2 or more races, where all those individuals who report more than one race are categorized together. So how you capture race and ethnicity on survey data is a very rich topic, and the census is doing a lot of testing on this to explore improvements in the questions because they know there's an interest in having more detailed and disaggregated data. So there's a blog here that I put the link to that you can read if you're interested in learning about the results of this testing. and the improvements that were made to the collection of race and ethnicity data in the ACS. This is how race and ethnicity data are collected on the New Jersey BRFS. It's very standard methodology of collecting information on Hispanic or Latinx or Spanish origin, and then moving on to having respondents select a race category. In this case, they are allowed to select one or more. There is a distinction in the BRFS in that there is a question which asks respondents who do report more than one race category for a single identification. And finally, this is how race and ethnicity data are collected on the CPS. Similar procedure. The data that are produced on CPS from the Census Bureau, the steward, uses the process of coding things as race alone or in combination. So tables will be presented for individuals who report a single race, and then the table will be repeated for individuals who report that race alone or in combination with any other race. So that's generally how you'll be able to find data by race ethnicity from the CPS. So moving on to information on sexual orientation and gender identity, the New Jersey BRFS does have a specific module to collect this information. It was used in 2020 through 2022 survey so far. There's a lot of health content on the BRFS with questions that rely on knowing the respondent's sex at birth or biological sex. So that's why the survey can't be conducted if individuals don't respond to that question. And you can read more detail about this module in the link at the bottom if you're interested. So here's the summary table again of the 3 surveys and the information that they collect on race, ethnicity, biological sex, and gender identity. The ACS allows for the most detail because it has those unstructured write-in fields. The New Jersey BRFS is unique in requesting that primary race identification. All of the surveys do collect biological sex or sex at birth. There's no questions in the ACS or the CPS that explicitly acknowledge gender identity, but I do want to note that in the most recent BRFS survey, they did add a non-binary answer choice. So when the question is asked, are you male or female, the interviewer can code non-binary if a respondent answers that way. The BRFS also has that sexual orientation and gender identity module, which I mentioned, which does collect information on sexual orientation and asks respondents if they identify as transgender. There's no such direct questions like that on the CPS or ACS. However, because these surveys do roster the entire household and ask about relationships, you can identify same-sex couples in the ACS and CPS. Of course, they have to live together, but recently, in those answer choices for relationships, there have been added explicit categories for having the individual being an opposite sex spouse or a same-sex spouse, an opposite sex partner, or same-sex partner. Okay, so I'm at a point again where I'm going to stop and see if there's any questions.
Yes, we have a couple good questions in the chat. So the first question, Kristen, is from Shin Yi, and they ask, is race ethnicity a required field, or is there a prefer not to answer option in addition to those options?
Yes, there is always an option to refuse or say don't know. Often if an interviewer is administering the surveys, they won't read those options. They will read the answer choices and to probe the respondent to give an answer, but absolutely those questions can be refused.
And just one other question we have here, which kind of refers to the previous section. Did any of the surveys add any questions due to COVID-19, starting with 2020 healthcare coverage? For example, adding or switching wording to address telehealth in terms of unmet care for reasons other than cost, or the continuous coverage requirement?
So the ACS didn't add anything related to COVID. Instead, the census put out the Pulse survey, which I'm not covering here, but the Census Pulse survey does have a lot of very COVID specific questions. So there's no modifications to the ACS on that. The CPS and the BRFS, I think they did, I think the CPS may have added a question or two. I'm not remembering it right now, but I do have it written down. And when we circle back in the Q&A later, Joe, just remind me to come back to this.
Absolutely.
Okay. So this section coming up is about accessing the data and analysis guidance. And I'm just looking for time because I can't see a clock to make sure how I'm doing on time. Joe.
It looks like you're doing fine. So,
all right, thanks.
yeah.
Because I do have slides here, which I will go very quickly through if I'm running out of time. So this is how I bucket data access in my mind. The first group would be everything that isn't working directly with microdata. So there's a lot here. The data stewards for each of these surveys do provide tons of tables, charts, graphs. There's online analysis tools, which will query the microdata. Lots of other policy groups and policy research groups put out data from these surveys, Pew, SHADAC, Kaiser Family Foundation. So there's a lot in group one, which I'm lumping together. But in general, the pros and cons are that you don't need to have any specific skill with any kind of software or coding to get the data this way. You can just access it. And the major con is that you're limited to how the data are prepared by the authors. So what classifications and categorizations they decided to use. So just a case in point, when I was making the slide on insurance rates, I didn't want to pull down microdata and do it all. So I was looking for published information and I wasn't able to find, uninsured for New Jersey, the CPS for ages 19 to 64. I had to use 18 to 64. So that's, one of the small drawbacks when you're using what's already out there. So if you are going to use data that are already put together by somebody else, you should just make sure you read all those footnotes, and particularly when you're looking at coverage to see whether they use any hierarchies in assigning a coverage to them, because when people can have multiple types of coverage, usually there'll need to be some kind of hierarchy for putting everybody in one bucket. The second group here is public use microdata, and this is data that's provided by the steward. It's record level data for a sample of responses. This goes through a disclosure avoidance processing to make sure that you can derive valid estimates from it, but it reduces the risk that anybody can be identified in the data. The pros and cons are pretty much reversed. You have the maximum flexibility when you work with the microdata, but you do need to be able to extract, prepare, and analyze it using some kind of software. Plus, there's a little lag in availability. I want to mention there are also restricted microdata available for these surveys. We're not talking about that today, but it does exist for each of them. And the last group here is, I guess it's kind of like a subgroup of number 2, but it's the IPUMS. It used to stand for Integrated Public Use Microdata Series, but that acronym just became the name now. The pros and cons are pretty much the same as for the public use microdata with some additional. I am going to talk a little bit more in detail about the IPUMS in a later slide, so I'll not discuss any further here. So now there's multiple ways to get the data from the survey and multiple surveys. So I'm going to try to go through quickly where you can access the data for each of them. And again, this will all be in the slides with the links later if you need that. So I'm not familiar with a lot of the tools, the census publications that they put out on the ACS. There's just so many of them, but I do use data.census.gov. And this is really the new incarnation of what used to be called American Fact Finder, which may sound familiar to you. So this website is a point and click filter system. You download the data by geographic unit. If you want data at small geographies, this is where you have to go to get it for the ACS. They just upgraded this in the fall of last year so that you can easily pull batch geographies, which is great. There's many online tutorials on how to use it. I find it very user-friendly, couple minutes of tinkering and you'll have it. In the bottom right of the screen is just an example of what the data will look like if you pull it from data.census.gov. So this is health insurance status in New Jersey. And you see you get your estimates, you get your 90% margin of error. And I did also put a link there on the bottom to a statistical analysis tool that the census provides so that you can do statistical testing of differences in data when you pull it from data.census.gov. So CPS data is not available on that data.census.gov website. So in order to get tables on the CPS, you do have to go to the website that's shown here. They have data tables published for many different topics. By default, it will be national estimates and not state specific. I really can't find any state specific published tables from the CPS directly from the census. And they may be there. There's lots of rabbit holes to go down looking for these tables, but it's not what's prominent and easy to find. This is an example of what the data will look like when you open that Excel file. This is health insurance coverage in 2020 from the CPS. So there is this new online table generator that's currently in beta testing where you can get data from the CPS and the ACS. It will query the microdata in the background. I've not used it. I'm not really familiar with it since I do prefer just working with the microdata myself, but this is an option if you don't work in any statistical programs. I'm sure there's a learning curve to it, but it's probably pretty powerful once you understand how it works. And again, for getting data from New Jersey BRFS, kind of in that first bucket where it's already tabulated, is to use the New Jersey State Health Assessment Data website, or the NJSHAD, which is, the link is at the top here. This provides crude rates, age-adjusted rates. You can choose how you want the data to be presented, a table, a graph. You can cross different variables, so you can get coverage crossed with key demographics. The resulting table will give you margins of error, confidence intervals. There's a help page. I think somebody had a question when they were registering about how to use it. So there is a help page available, and that link is here at the bottom. It's a very user-friendly tool, I think, and an interesting feature that I think is great about it is that when you can, working with the BRFS, you can pool multiple years of data automatically. So you can select several years. If you find your estimates, you're working with too small of a sample size, it will allow you to select multiple years. You can also get BRFS data through the CDC webpage shown here. The estimates are for all the states, and you can get information for the whole country, but you can also limit to just New Jersey. So again, the CPS is really the only one where it's a little hard to find New Jersey specific data already available and published. Now moving on to the public use microdata. So this is the website for getting the public use microdata from the ACS. It's all posted on an FTP site. It's organized by state. You can download a SAS file or a CSV file. You get a person file and a household file, so you have to link that together. This is this document here with the link at the bottom will give you even SAS code for putting those together. The smallest geographic unit available in public use data is the public use microdata area, or the PUMA, and that is population groups of about 100,000 that aggregate up smaller census geographies. So just to note, when you work with the microdata, you can't get any smaller geography than a PUMA. And as context, in New Jersey, there's about 73 PUMAs. They're roughly sub-regions of counties. And here I just wanted to give you what was a sample size in the public use microdata for New Jersey from the ACS in a recent year. It's 88,400 people. To access the BRFS public use microdata, you would go to this website. That's an annual file, so all the states are together. You'd have to pull out New Jersey separately. The data come in SAS. There's SAS resources available for use, or you can get ASCII2 and import it to whatever software you like. There's lots of documentation here right alongside so that you can figure out how to work with the data. And here's that recent sample N for New Jersey of 11,382 people. And finally, the CPS public use microdata is available at this website. The data come ASCII2, SAS, or CSV. There's a family file, a household file, a person file. You link it all together. The technical documentation is right there to direct you on how to do that. And the sample is 3,030. I think this was in the 2021 CPS, which pertains to year 2020. And as you can see, it's quite a small sample compared to the other two surveys. And finally, I'm introducing the IPUMS. If you've never heard of this, the IPUMS is a great resource. This is their purpose and the slogan that they use. IPUMS is part of the Institute for Social Research and Data Innovation at the University of Minnesota. This is free data. It's a great resource. They also do other surveys besides the ACS and the CPS. And because they're also within the University of Minnesota, the way SHAD is, those two groups work together to sort of add value to the IPUMS data. So I don't have time to go into a lot of the value that's added when you work with the IPUMS data, but this is how I will access microdata for either of these surveys. You can curate your own sample and exactly the variables you want. It will give you an extract that you can, and the code so that you can read it in and format it all in either SAS or SPSS or Stata. There's an IPUMS R package that's been developed. There is also an online analysis tool that IPUMS has developed. I've not used it, but I want to mention it because it means that you can still benefit from all IPUMS has to offer, even if you don't code yourself in any statistical package. Their purpose is really to harmonize a lot of variables over time. So it is really useful and helpful. You'll get variables here that you cannot get if you get the public use microdata directly from the census. The downside is they don't do the BRFS data, and there's also a greater lag before it's available in IPUMS. So jumping now to just some tips for analysts who might be working with one of these surveys. They're all complex surveys, so you have to use proper weighting in your estimates and correct for the design features. This is just a reminder here of the different weight variables that are available for each of the surveys. There's replicate weight files that will come when you download the microdata, and there's resources for how you should use those properly. In the BRFS, you would have to specify certain design features in your code in order to calculate standard errors and confidence intervals. It's often a good idea, I think, if you're working with microdata, to compare your estimate to something that is already published, even if it's just a ballpark, to see that you're in the right range. And generally, when people use these data, they're using it to link it in by geography to another data set. Either you're working with it alone or you want to link it into something, and that's generally done by geography. So either linking it in for the whole state, you're linking in estimates by zip code or block group, or whatever your analysis requires. These are resources for working with the public use microdata that I think are really helpful. Particularly if you're working with the BRFS, because of the way some optional modules are administered, you really need to rely on this guidance for doing the analysis correctly. I think that the IPUMS guide, the guidance on the CPS from the IPUMS is really helpful, especially in understanding how to use the replicate weights. All of these documents will give you specific codes as well. Like mostly SAS is what's supported. That's the most consistently supported software that I see. But they also do have code sometimes for Stata, SPSS, and even like Sudan and WestStat, which I've never worked with. Another issue is dealing with small samples when you're analyzing these data. So there's some rules of thumb for not creating estimates that are based on too small of a sample, because that would make it unstable. So in opinion surveys, having a margin of error of less than 3 percentage points, it's a commonly used standard of reliability. The census and the BRFS also will recommend that you at least have a minimum N of 50, or this idea of a relative standard error, which is when you divide the standard error by the estimate, that you are under 25 or 30%. Anything above that is commonly flagged as unreliable in a government survey. And if the statistic that you're looking for is based on too small of a sample, another option could be pooling multiple years. As I mentioned, the ACS does have a 5-year file that they put out, but if you want to combine years of either the CPS or the BRFS, as I said, when you're working with NJSHAD, you can do that automatically. But if you're working with the microdata, these are just recommendations for how you would scale your weights so that you can produce accurate estimates from the pooled data. Here's just some trending cautions if you're working with it, specifically for analysts to know where there might be issues if you're trying to trend something over time. We will be talking about the COVID impact shortly, but the CPS, as you can see, especially with related to coverage, because of that significant redesign and this new data processing, has the biggest trending cautions related to the coverage variables. So I am going to pause here again and see if there are any questions.
So we do have a question, Kristen, from Alan, and he asked, are there geocodes besides the state IDs that can be used in these surveys?
Yes. So if you're working with the ACS, there are, yes, you can get all those census identifiers. If you're pulling from data.census.gov, you can get the block group identifier, the census tract identifier, the block identifier. Of course, you'll need to be in the 5-year file for that. Otherwise, there isn't enough sample for that small. There are county identifiers in the BRFS. So is it FIPS? I think there's a standard set of codes for county identifiers. That's also available in the ACS. There's in the CPS, I believe the identifiers only go to state and perhaps a metropolitan statistical area. I don't think there's anything smaller than that. Let me see, is there any other questions? Thank you for these questions, they're good. Okay. So now I'm going to quickly go through what happened to these surveys with COVID. As you can see, it impacted the response rates for the ACS and the CPS-ASEC. That impact is most pronounced for the ACS because there was more interruption to the data collection. These response rates are still quite high compared to private polling surveys. The BRFS, I've not seen anything that the response rate was really significantly lower due to COVID. The BRFS data are collected via telephone, and so that was less interrupted by stay-at-home orders. The ACS requires mass mailings and huge phone banks, and mailing centers were shut down, and those big calling centers were shut down. So it was a much bigger interruption for the ACS than for the BRFS. Now, this summary slide is color-coded kind of by caution level. The ACS has red because they urge the most caution with those estimates for 2020, and the BRFS has the least caution for the estimates for 2020. So non-response doesn't on its own mean that there's any problem in the data, that they are biased, but research on the ACS and the CPS-ASEC did show that during 2020, there was differential non-response. So more advantaged households responded to the surveys, and individuals who were lower income or lower educated were less likely to respond in 2020. In order to remedy this, the census for the ACS created an experimental weight. They brought in a lot of administrative data to try to create a new weight that would correct for that differential non-response, but they still urge a lot of caution when using the ACS data for 2020 and call all of those estimates experimental. The CPS-ASEC was also affected, but a little less so, because remember, it's only collected February through April. And really, as we all know, COVID and the shutdown really started in March and April. So there was at least a little bit of time where it was uninterrupted. There's also, they don't do mailings for the CPS. They do home interviews when people first come into the sample, and then follow up with telephone. So there is a telephone data collection system in place for the CPS-ASEC. PUMS did create a weight to help correct for that. So if you work with the microdata from PUMS, you can use that weight to help correct estimates for 2020. And I didn't see any particular caution for the BRFS about any differential non-response. And as I mentioned, seems to have been less impacted by COVID in 2020. These are just some resources for analysts if you're going to be working with the data that I find useful. SHADAC in particular has lots of briefs that provide SASN's data code. There's user groups for the American Community Survey. There's webinars, data gems. There's guidance for NJSHAD from the New Jersey Department of Health. And you can call the census. I've done it and always had luck. They're friendly. They answer the phone. At least they did before COVID. I'm assuming they do now too. And they'll help answer the questions, and they seem happy to talk about it. So that's always an option if you can't find the information you want in any of the online technical documentation. And finally, here are just some key takeaways about each of the surveys for policymakers or individuals trying to decide which one to use. There's the major strengths and weaknesses of each of them. and you can read that here. I think that the ACS really does have that large sample, which is its biggest benefit. New Jersey BRFS does have that rich data on coverage and timely inclusion of these modules that have current research and policy relevance, and the CPS does really get into a lot of coverage dynamics in great detail. So, and it has the longest, it's the longest running, so has the most years of data if you're looking to do like a longitudinal study. So thank you very much. Just to reiterate, the webinar recording will be posted, and the slides, so you will be able to access them, and there will be a post-survey webinar that you will receive upon exiting, so please fill that out. And now I'm going to take questions. We do have people who registered who are proficient in a lot of the surveys, so it can be a sharing of information. Feel free to chat and answer. Everybody will be given the ability to unmute, so you can chime in if you have some helpful information to share. Okay. Let's see if I can do this right. Okay. So, are there any questions?
This is Barbara at the Center for Health Statistics. I just wanted to thank you for a comprehensive overview of the BRFS survey data. And I just wanted to point out to the listeners that although you may be able to go to NJSHAD to see some of our summary data from BRFS, just as you emphasized, it's a much richer data set than you'll see there. So if individuals are interested in looking at some of the variables that are just specifically asked by New Jersey and not other states, or if they need information that's not available through NJSHAD, we can share raw data if IRB approval is received. So you can certainly reach out to us, and we would be willing to go through any caveats or anything that needs to be addressed with regards to the data.
Great, thank you.
Kristen, this is Alan. Can you hear me?
Yes.
Okay, so with regard to the Medicaid undercount, I'm also thinking that the growth of Medicaid managed care over time may have confused respondents who are now reporting, non-group coverage as opposed to Medicaid, because they essentially get a card that, that identifies the managed care entity that is providing, coverage. So the Medicaid undercount then has some implications for estimates of non-group coverage. There's that kind of trade-off with regard to that.
Yes, that's a good point. Most of the research that I see done on it is national, not specific to a state. And as you know, managed care kind of in Medicaid rolled out really at different times, and there's different amounts of people who are in Medicaid managed care in each of the states. So I didn't see any analysis that was specific to that, but that makes perfect sense that they're going to identify their insurance as United Healthcare and think of that as a direct purchase coverage as opposed to it being a Medicaid coverage.
Right.
So Kristen, a question that just occurred to me is, which of these surveys do you think is best for doing research on the uninsured population, and why?
I think that the American Community Survey to me is the best for that. Main reason being it's a point in time measure of the uninsured, which while the BRFS has that, the ACS will cover children and have that question answered for children. So I think it covers the full population, and it has a point in time estimate, and it has a lot of consistency over time. So I use mostly the ACS when we do estimates on the uninsured.
Thank you.
Mm-hmm. There are, and I would use it from the PUMS because there is some additional data processing that the PUMS will do, some other logical edits that are applied to help remedy that Medicaid undercount. And so I think that improves the reliability of those estimates from the ACS, because it does, that Medicaid undercount does, you know, when you pull people into Medicaid, it will change some of who falls into that uninsured bucket. So it does help refine the estimates for the uninsured as well. There were many things I did not go through, which I could, if anybody had any further questions on them. I feel like a walking advertisement for the IPUMS, but they do add so much. I did want to mention, I think somebody put a note when they were registering of something they were interested in learning about, and that is, you know, how do you tell which, you know, what variables there are and what the categorizations are. And when you go to the IPUMS, I think that's the easiest way, because they just have a data dictionary. When you select the variables, that will give you, here are the codes and the categories, here's the universe, here's the questionnaire text. And so I just find that very easy for the ACS and the CPS to go in and understand what variables are available, what years they're available for, and exactly how they're going to be categorized in the microdata.
And we have another question here in the chat from Xin Yi, and they're asking, so they work on maternity-related initiatives, so they're wondering if any of these surveys allow you to highlight insurance coverage for pregnant/postpartum population, or based on any other clinical features.
There's, when the question is asked about coverage, I know there are some programs through Medicaid that will cover specifically in the pregnant or postpartum period that won't be distinguished in the question on coverage. However, the surveys, I'm sure the BRFS does. I don't think the ACS asks a question about whether an individual is currently pregnant. I know the ACS does have questions about the number of children, younger children in the households under 5. It also asks about, I think it may ask about some questions related to fertility, and I'm not remembering specifically what they are, but you may be able to combine that with the answer to the coverage questions to understand that dynamic. And because, you know, you do have everybody in the household covered, you would know if there was a infant identified in the household as the child of a respondent or a female. So that might help with what you're asking about too. Again, my little IPUMS plug here is IPUMS does provide really great family relationship pointers. So you can attach those characteristics on your file and you can understand, you know, who's related to who in the household and how. There's other clinical features, again, very limited in the ACS and CPS, a lot of much more likely to find that information in the BRFS. Oh, thank you, Nadia. Another thing that some people are also very interested in is whether the undocumented population is covered in any of the surveys. And it's not, there are no questions on any of these surveys that specifically ask about undocumented status. You can tell on the ACS and on the CPS, there are questions about citizenship. I think the BRFS does have a question about nativity to know whether somebody is foreign born or not, but you don't know if they're citizen or non-citizen. I don't think, I'm trying to remember for sure. So some people, you can try to proxy a certain percentage of those non-citizens who, you know, foreign-born non-citizens who may potentially be undocumented. The Migration Policy Institute, the Kaiser Family Foundation, these organizations do some simulations to using these data to try to estimate the undocumented population. So you can go to those resources, but as far as working directly with the data, you'll not find a question that will flag somebody as undocumented. I'm hoping that I addressed the topics that people were interested in learning about when they registered for the survey. If not, you know, please feel free to unmute and remind me of your question. All right, so there's a question in the chat. Okay, so are all the variables that are available for the summary data also available for the public use microdata for ACS? Yes, so the topics, the variables that would create any of those summary data tables would be available in the public use microdata. The only thing to remember is that you won't get the smaller geographies in the public use microdata. So if you can pull a summary data table that's for a zip code, you couldn't create that same table using the public use microdata because you wouldn't have that small geography available. But other than that, the characteristics, the whatever indicator it was you're looking at would be available in the public use microdata.
So just another question that occurred to me while we're having this conversation, Kristen, is, for the crosstabs, so how will I know what crosstabs will be available through the ACS if I were to pull that data from census.gov? Is there a list that will tell you, or how do I go about that?
It's a good question. So you can, I would kind of Google the ACS summary file and get to that website. And on there, there's an appendix, and that appendix document will tell you kind of all of the data tables that are available. And it will also tell you what geographies they're available at, whether certain things, even if they're you're working with the data.census.gov and could get it at a block group, certain topics won't be published for a block or a block group. So this appendix will not only tell you, okay, here's the tables that are available, but what geographies they're available for. And it will give you the table number because the census has all these tables numbered, so that when you're working with the data pull from that website, data.census.gov, you can actually even type right in that table number to get straight to that information. So yeah, it could be tedious if you're like, I'm not quite sure what I want, what's available, to just be pointing and clicking through data.census.gov, which, to find out if that specific cut you're looking for is available. So you can go to that appendix. Maybe before we post the presentation, I can put a link to that appendix in the slides so that people can get it easily.
Chris.
Yes.
Kristen, this is Zhong Yuan from EOHSI. First, great topic, great presentation, and I have follow up on the my previous question regarding public use microdata. So the geographic resolution for that, is that going to be the same? Because I know the census that they're going to state, county, census tract, census block group, and the block. So the PUMS geographic code, is that also falls into this FIPS code hierarchy?
Yes, so the public use microdata, the geographies that'll be on there will be anything that is a public use microdata area, which is a completely made up census geography, and anything greater than that. So it will have county, unless you're working in a state where the population in the county is too small to qualify it as a public use microdata area. So it's, I wish I had a slide kind of on the hierarchy of census geographies, but you would not be able to get on the public use microdata tracts, block groups, blocks, zip codes. That won't be there. Maybe it would be if you worked with restricted data, but then that's not the public use one. The smallest geography is going to be what's called the PUMA, and I think it has to have at least a population of 100,000. So only aggregations of geographies that have a minimum population of 100,000 or greater. I don't know if that answers your question.
So if I know a PUMA code, I could know which census tract it covers.
Yes. You can pull down PUMA maps from the census. They've got the whole country, and you can get that very detailed map that'll show you exactly the boundaries of that public use microdata area. And you can even see in there which tracts are included in that PUMA. So definitely go to the maps.
But it's not using FIPS code.
Not for public use microdata areas. There is a census code for that.
Okay.
It's not a FIPS code.
Thank you.
Welcome.
So we have another question here in the chat, a good one. So is there a response rate difference in each of the surveys?
Yes, there is. The response rate for the ACS and the CPS is quite high, being that these come from the government. I think I have down here in 2019 the ACS response rate was 86%. In 2019 the CPS ASEC response rate was 61%. That's an estimate. And then for the NJBRFS, the response rate, well, 2019 the data weren't collected, but in 2020 it was around 34.5%. And again, even for years, those are good response rates, and doesn't necessarily mean that anything is wrong with the data just because the response rate is lower. It's only if it's really kind of a differential non-response, which is what happened during COVID. And there's a lot of data processing and weighting procedures to try to account for some of that non-response to help give valid estimates. All right, so I just want to remind everybody that the slides will be posted, and I hope they are useful to you, and that you are able to work with these surveys, because they are really great and there's a lot of rich data in them. I thank you very much for attending today. I will leave it to Joe to decide if we should hold on to make sure there's no other questions. Or anything anybody would like to add who works with these surveys and knows additional helpful information.
It looks like you're just getting accolades in the chat, not questions. Well deserved. Thank you, Kristen. This was really wonderful. And also like to remind folks to fill out the feedback survey. When you click off, it should come up. Anything else?
No, thank you all very much for attending. I hope you learned something and it will help you at some point in your research.
Great.
Thanks.
Bye, everybody.
Okay, thanks. Bye.